We're going to talk about Cushing Syndrome. This is also known as hypercortisolism. When we talk about the syndrome, this is a constellation of clinical abnormalities, which is caused by chronic high levels of cortisol or cortisol-related steroids. Okay, this is separate from the disease, which is generally from excess pituitary production of ACTH. And again, it's generally due to an adenoma. However, when we talk about a Cushingoid appearance, Cushing syndrome, this is generally what we're speaking of. So, brief review of the adrenal function. During our Addison's disease talk, we really focused on the adrenal gland and, in particular, the adrenal cortex and the outer edge, which includes aldosterone production, cortisol, and androgen, but aldosterone is kind of the main dysfunction that happens in Addison's disease. With Cushing syndrome, we're going to be focusing more, again, on this cortex and the cortisol. So once again, the adrenal glands, they're located on the cephalad portion of each kidney. We usually have two. The outer layer of the cortex is the zona glomerulosa, and it's full of cells that secrete aldosterone, which works together with the renin-angiotensin-aldosterone system. And basically, these hormones decrease our potassium levels, increase our sodium levels. With sodium generally flows water, so it's meant to increase our blood volume, maintain our blood pressure. It also helps with pH balancing, and then it stimulates those sodium, potassium, ion pumps in the kidney, and that distal nephron that results in urinary excretion of protons, and then it helps move bicarb into the extracellular space to increase our pH, right? It keeps us pH balanced. So the middle layer of this cortex is the zona fasciculata, and there is where the hormone cortisol and other glucocorticoids are made, and that is what is going to be our focus today. We don't want to forget about the rest of the adrenal function. Of course, androgens are produced here, and then we have the medulla, which secretes catecholamines. So as we focus on cortisol today, let's just do a quick cortisol function refresher, okay? Cortisol is essentially released from our adrenal glands. However, it is regulated by our hypothalamus pituitary axis. It is regulated via a feedback mechanism. So we generally have our hypothalamus releases CRH, which stimulates the pituitary to release ACTH, and then the ACTH travels through our bloodstream. It stimulates our adrenal cortex to release cortisol. Okay, so cortisol is super important in many aspects. In fact, almost every body cell has a cortisol receptor, and it has a huge variety of effects on functions in our body. So cortisol can get to the muscles and break down proteins into amino acid. It can also get to our adipose tissue to break down fats into free fatty acids. So both of those can help provide the liver with those raw materials, right? Our amino acids and free fatty acids, so it can perform gluconeogenesis, i.e. formation of glucose from non-carb resources. So basically, cortisol helps bump up blood glucose levels in high stress times, in those times we have fight or flight reactions, okay? So it's involved in a number of other organs. It's involved in our circadian rhythm. The cortisol actually peaks in the morning when the body, hey, we got to get up, got to get moving, got to get going, and then it drops in the evening when we sleep, okay? It also maintains blood pressure. It increases the sensitivity of our peripheral blood vessels to catecholamines, and so that results in the narrowing of those vessel lumens, so it helps raise the blood pressure. Cortisol also helps to dampen our inflammatory and immune response by reducing the production and the release of our inflammatory mediators. These are like our prostaglandins, our interleukins. It can help inhibit the proliferation of T lymphocytes. Remember, people with autoimmune or hyperimmune states are given steroids to kind of dumb that down. This is why it works. And then also cortisol receptors are present in the brain. I'm honestly not sure why. I don't think their full effect is completely understood, but they seem to affect mood and memory. So as we move on to our actual point of this lecture, we want to talk about Cushing Syndrome. Again, we talk about Cushing Syndrome. It is a state of hypercortisolism, adrenal overexcretion of cortisol. Now, this happens two ways. There is ACTH-dependent hyperfunction. So this is Cushing disease. Most of the time, and I'll say this again, most of the time, excess ACTH is from the pituitary gland because there's a pituitary adenoma almost all the time. Okay, this is the most common reason for it. So hypersecretion of the cortisol comes from the adrenal cortex, but it's because there's excess ACTH floating around telling it to secrete. There can be ACTH secretion from other tumors. Most commonly, this is from small cell lung CA or carcinoid tumors, and there can also be exogenous ACTH administration for other disease states. The other form of Cushing syndrome results from ACTH independent hyperfunction, okay? This is independent of the pituitary. So either we're giving the patient steroids to help with their autoimmune disease or an inflammatory disorder over a chronic period of time, or the adrenal gland itself is hypersecreting because it has a tumor within its own organ, okay? And again, there can be a carcinoma hypersecretion of ACTH in cortisol itself. So signs and symptoms. This is a classic textbook kind of picture. This picture is derived from the Merck Manual's Professional Edition online, which I've given as a source, and there's a hyperlink here. And this person has the typical moon facies, we say, has this round appearance. They generally have some truncal obesity with prominent supraclavicular and dorsal cervical pads. We call this the buffalo hump, and you can appreciate that on either side of her neck. If we turned her sideways, we'd see that towards the back as well. Generally, we'll see very slender distal extremities in fingers. This is because of the muscle wasting, and so it's just kind of, that's why we have this truncal obesity appearance. Also because of basically the way the excess cortisol leads to high insulin levels. Because of the high glucose levels, the insulin ends up having a lot of different action, and one of those activates a lipoprotein lipase that actually helps adipocytes accumulate more fat molecules. So that's where that central obesity comes from. Again, lots of different effects. These people will have this kind of, we call it violaceous striae. Okay, these are stretch marks in places you shouldn't really have stretch marks, right? You see she has these across her chest, shoulders, arms. It's just not normal. Thinning of the skin will happen, easily bruising. Women will have menstrual irregularities. And then if this is a primary adrenal tumor, because the adrenals secrete androgens, which most women get their testosterone from, which is very limited amount, with a tumor, you're hypersecreting high androgens, so that will end up in some hirsute appearance. You'll get some temporal balding in females, but they'll be growing some hair. And this person looks like they may have that problem. Actually, you see a little bit of abnormal facial hair here. So with diagnosis, our diagnosis is going to be a little bit complex here. First of all, our history is key. So history and our signs and symptoms will lead us to a suspicion. We see this person with the striae, the moon phases, the buffalo hump. We're going to be thinking about this and our differential. So when we send off labs, we'll be looking at urinary free cortisol. This is a 24-hour urine collection that can be done many places. I feel like this is a very burdensome test to run. I'm not sure in practice if many people do this anymore, but they will run and look at the cortisol in that 24-hour collection, and if it's greater than 4 times the normal limit, it's slam dunk diagnosis. If it's greater than 3 or less than 3 times the normal limit, or you're not 100% sure, you'll proceed with that midnight level. Again, cortisol production should have a kind of a biphasic spike, so we can look at it baseline around 9 a.m. and then midnight. There should be that normal rise and fall. The other thing that we can do is a dexamethasone suppression test. So we give dexamethasone. ACTH should decrease if we have a normal feedback mechanism, normal pituitary adrenal axis, and so then we should repeat a serum cortisol and we should see a drop in that, right? The other testing that we can do would be to do some provocative testing, or get a baseline ACTH level. If it's low, it's indicative of independent disease. So we're going to be thinking of independent hypercortisolism. So we want to suspect the adrenal gland itself to be hypersecreting, or another carcinoma. So we're going to want to go down that route of suspecting the adrenal adenoma and then do some imaging. Now, if our ACTH is high, that's indicative of Cushing's disease, a pituitary problem, versus an ectopic tumor. Perhaps you suspect lung cancer in this patient, or they have a history of lung cancer, okay? So then we need some provocative testing to decide if this is a primary pituitary issue or if there's an ectopic tumor production. So we will administer dexamethasone, and in that case, the tumor that is hypersecreting is not going to respond. It doesn't have that feedback mechanism that the pituitary hypothalamus do. So the cortisol will remain high, and in that case, we're going to be doing a lot more scanning. So our next step would be imaging, in which we obtain an MRI with GAD if we're suspecting a pituitary adenoma. And if it's a non-pituitary cause, we're going to be getting a high-resolution CT of the chest, pancreas, adrenals versus a PET scan. Of course, in a pregnant woman, we're always going to be using an MRI because there's no radiation involved. So once we work our patient up, we are going to base our treatment based on our findings. So we're going to aim our treatment at the underlying cause. We will need to be replacing potassium and looking at electrolytes and high protein diet because we're constantly needing to access those amino acids. We're having muscle loss and wasting, so we want to focus on maintaining those sources of energy. If we are the ones causing it, we need to slowly taper off the offending drug. So if somebody's on a long-term exogenous steroid because they have rheumatoid arthritis or lupus, this needs to be a very slow wean withdrawal, because if we abruptly stop, we can send this person into an adrenal crisis because we've caused atrophy of the adrenal glands for so long, and that can be a life-threatening crisis. That is something that we're always looking out for in the ICU. Supportive care, We're also going to be doing surgery. The best way to take care of a pituitary adenoma is to remove it. Okay, send them off to neurosurgery consult. Sometimes we can irradiate these things, and also removing ACTH secreting tumor or an adrenal tumor. If they are not a surgical candidate, or we have an already aggressive cancer that's metastatic and you have multiple foci of ACTH secreting tumors or cortisol, we can do adrenal steroid inhibitors or ACTH suppression. I don't expect you to remember all of these. This is a super specialized area. These people are going to need to go to an endocrinologist. That is the end of our exciting talk about Cushing syndrome. I hope you enjoyed it, and I hope you have a great day.